Hi dear doctors, welcome to 𝗲𝗵𝗴𝗿. I am Dr. Parv and I am your pediatric faculty. In this topic today we are discussing about an important topic that is called as imperforate anus. So what happens is in imperforate anus the anal opening is something which is imperforated, okay, and because the anal opening is imperforated the child is unable to pass the stools. So what is imperforate anus? It is a congenital defect where the anal opening is absent or anal opening is misplaced, okay. Where the anal opening is absent or anal opening is misplaced, it is not placed properly, right? So what happens in this, sometimes there will be anal stenosis because the opening is not proper, so anal stenosis is going to be there, or sometimes there will be some abnormalities related to cloacal abnormalities, okay. It is actually equal in case of males and females. What is the pathogenesis? Please understand that in the early gestation like 3rd to 8th week, what happens is that there is a development of cloaca. There is a development of cloaca, and in this development of cloaca there is a septum which is called as urorectal septum, okay. There is a septum which is called as urorectal septum, and this urorectal septum is somewhere responsible for the formation of anal opening, this urorectal, because it's a septum between the urinary part and the gastrointestinal part. So if it is not formed properly, either there will be stenosis of anal canal or the anal canal will not be able to open at a right place, right? Now this is something which is associated with VACTERL syndrome. Now what is VACTERL syndrome? V for vertebral abnormalities, A for anal canal issues, C for cardiac issues, T for Tracheo-Esophageal fistula, E for esophageal, R for renal, L for limb abnormalities. As I always teach students like this, like first of all you have to check the limb abnormalities, then you have to check the anal abnormalities, then you have to go to your vertebra. So this is the vertebral abnormalities, and on the sides of vertebra there is going to be kidney, so there will be renal abnormalities. Then you have to ascend up and up. So up means cardiac abnormalities, and more up is going to be tracheo-esophageal fistula, okay. So this is the easy trick to remember, VACTERL syndrome. Now what happens is that there are two types of obstruction. One is going to be a low obstruction, other is going to be a high obstruction. So what is important in low obstruction? Low obstruction means that the anus is displaced anteriorly, okay. The anus is displaced anteriorly and the fistula is going to connect the perineum, okay. The fistula, the opening is going to involve what? It is going to involve the perineum, okay. Whereas high obstruction means that the obstruction is at a high level, it is at the high level, so that's why the fistula is going to develop either in the vagina or in the urinary tract. So if you can't imagine, just simply see, understand the vaginal opening is of course above, the urinary tract opening is of course above, the perineum is of course below. If I just make this diagram to show you guys, please understand that this is your perineum, right? And in the perineum, okay, if this is your perineum, then you have got some defects, not defects actually, some openings, like this is the bladder opening which is going to be there, okay. Then you have got the uterine opening, okay. Then you have got the bowel which is opening. So of course if the fistula is getting hair or if the fistula is getting hair, so these are high ones, whereas if it is connecting to the perineum, this is going to be the low one. So this is the classification. So what happens is, because it is imperforate, of course in first 1-2 days there will be no passage of stools, and yes, there will be abdominal distension which is going to happen, okay. And one important thing is that generally in the boys there is meconium at the fistula. Wherever the fistula is formed, the meconium is going to come, okay. Meconium at fistula, okay, called as white pearls, okay. Bucket handle skin tags, there will be some skin tags also, okay. And in the boys having the high lesions, there will be flat buttocks, meconium at the urethral meatus, okay. In girls, there is rectovestibular or rectovaginal fistula, because of course vagina, females, rectovaginal fistula. And there are some cloacal deformities also that leads to gastro-urinary tract obstruction. I'll make it simple for you. I have told you that the clinical presentation is little different in boys and in girls. And of course, that's true if the level of obstruction is low and high. So if it is high level of obstruction, girls are going to have the vaginal fistulas, okay, whereas boys are going to have what? Boys are going to have urethral meatus. So meconium is going to occur at where? Meconium is going to come at the urethral meatus. Whereas in lower obstruction, what is going to happen? Of course, there will be meconium at the place of the fistula, which is called as 𝗵𝗺𝗺. And one more thing is bucket handle skin tag. So B for boys, B for bucket handle skin tag. B for boys, B for bucket handle skin tags are going to be there. And what about girls? So in girls, you will be having what? If it is low, there will be obstruction. Okay, there will be obstruction, genitourinary tract obstruction, cloacal deformities are going to be there. So how to diagnose it? See, of course, the abdominal USG is done to see for the gastro-urinary tract. Sacral X-ray is done to see some bony abnormalities, and spinal USG is done to rule out the tethered cord. Not very important, just you should know whatever I have told you. But see, for some obvious reasons, and there was some older tradition where we used to follow invertogram. Okay, we used to do invertogram. I'll teach you in detail how to interpret an invertogram. Okay, it is not an invertogram, it is invertogram. So what happens is invertogram is to determine the level of rectal pouch. It is used to determine the level of the rectal pouch in relation to the pubo-coccygeal line. So there is a line from the pubis to coccygeum. Pubo-coccygeal line is going to be there, and in relation to that you will see the rectal opening or the rectal pouch, either it is above or below, it is high or low. Okay, so how do we do anything? Baby is placed upside down, inverted, okay, and a radio opaque marker, just like a coin or something, is tapped to expected site of anal opening. Okay, and then X-ray is taken after 24 to 40, some hours of birth, right, to allow the air to reach to the distal rectum, so that the air can reach the distal rectum. Now you will do a pubo-coccygeal line from the lower margin of the pubic symphysis to the tip of the coccyx, and then you will locate that what is the exact position where you can see the distalmost rectal shadow. Okay, then you are going to check. For example, now let me just show you in this diagram. You have done a pubo-coccygeus line. You have formed a pubo-coccygeus line, and you can see that this is the place where it is opening. So what I have told you, that draw a pubo-coccygeal line from the lower margin of the pubic symphysis to the tip of the coccyx, locate the distal rectal shadow and interpret on the basis of PC line. If it is below, like see, can you see here, it is exactly below. Okay, it is below the pubo-coccygeal line. Okay, so because it is below the pubo-coccygeal line, the management is going to be different. Whereas in high lesion, if it is higher, okay, then the things would have been different. Okay, the treatment would have been different. So if it is a low lesion, you have to do anoplasty. Okay, so anoplasty means create an anal opening, okay, and close the fistula. Okay, and if it is a high lesion, then what you are going to do? Initially we do sigmoid colostomy. So high lesion means it is at the level of colon only, so we will do a colostomy. That means you will direct the opening of colon outside the skin so that the meconium can pass through that. Do a sigmoid colostomy. Then you will do a anorectoplasty, posterior sagittal anorectoplasty. Okay, so posterior sagittal anorectoplasty means again close the fistula and reposition the rectum at 3 to 6 months. Okay, so this is the thing which we have to keep in mind, but please don't forget about the pubo-coccygeus. This you have to do. Okay, pubo-coccygeus. So even if in this image I'll try to show you, see, this is the tip of the coccyx. Okay, this is the tip of the coccyx which is there, and if you can see properly, somewhere here is going to be the pubis. Okay, so this is the pubo-coccygeus line, and here you can see that there is a distal shadow which is going on. So this might be not surely, but this might be the case of what? High opening. Okay, not high opening, it's actually below the PC line. Okay, and below the PC line is actually which lesion? It is a low lesion. Okay, below the PC line is going to be which lesion? It's going to be a low lesion in vertebral. Okay, so this is about the imperforate anus. Thank you so much for watching. We'll see you in the next video.